Thank you for joining us for this next session in the Canadian Breast Cancer Network series Questions and Experts. I'm Jen Gordon, Director of Operations with the Canadian Breast Cancer Network, and I'm pleased to welcome everyone to the session today. For those of you who may be interested in our previously recorded sessions, you can actually find those on our website, cbcn.ca, and I'll actually put the link up in the chat box in a little bit. We will be hosting these Q&A sessions on a monthly basis, and so some of the future sessions that you may want to watch for are questions around triple-negative breast cancer, where you can ask a medical oncologist. Drug access navigator will be joining us in terms of how to navigate some of those drug access challenges, a naturopathic doctor taking your questions around some of the complementary therapies, and then a psychologist as well. So by subscribing to CBCN's e-newsletter, and again, I'll put that link in the chat, or you can visit cbcn.ca to do that, you'll be notified of any future sessions. I would like to extend our sincere appreciation to our sponsors for this session today. So our gold level sponsor is Viatris. Our silver sponsor for today is Novartis and Roche. And our bronze sponsors, AstraZeneca, Knight, Pfizer Oncology, and Ontario Trillium Foundation. So thank you for supporting this work and allowing us to facilitate this discussion today. So I'd now like to welcome our host for the session, Kathy Amandalea, who is the chair of the board of the Canadian Breast Cancer Network. And as someone who has personally experienced a breast cancer diagnosis, Kathy really understands the many questions that come with this. And in her volunteer role as the chair of our board, she really works to ensure that these questions are addressed and that patients really have all the information they need to make informed treatment decisions. So on that note, Kathy, over to you.
Thank you, Jen. So I'm very pleased to once again welcome everyone to this question and education session. The first two were an incredible opportunity to hear from some of Canada's leading oncologists and have many of our questions answered. I know today's session will be incredibly helpful for anyone trying to make decisions around breast cancer surgery, which is such a critical part of treatment. I'm pleased and honored to welcome surgical oncologist, Dr. Mark Basik. Dr. Basik is the medical director of interdisciplinary breast cancer team at the Siegel Center at the Jewish General Hospital in Montreal. He is also a surgical scientist at the Lady Davis Institute and an associate professor in the Department of Surgery and Oncology at McGill University. He is also the head of the Cancer Genomics and Translational Research Laboratory at the Jewish General Hospital. Dr. Basik, thank you for making the time to join us today. We will be taking questions throughout the session, and participants can submit questions using the Q&A icon at the bottom of your screen. We have had some questions throughout the session, some questions submitted in advance. So we will we will start with answering a couple of these to start off the conversation, while additional questions are submitted through the Q&A. So all this, we could start with one of the many questions that were submitted. So first question, Dr. Basik, is, could you elaborate on the option of doing immediate reconstruction? What are the pros and cons of this? And do you have any recommendations or cautions around different types of reconstructions?
First of all, thank you very much, Kathy. It's an honor for me to be here. I hope you hear me well. My computer has been a bit funny lately, but I'm happy to be here to answer the questions to the best of my ability. I've always I love the CBCN's work over the years, and I'm very, very proud to be associated with your work and with your outreach to the community, which this is a part. So the question about reconstruction is a gigantic question. Do I have about 2 hours or 3 hours?
I'm sure the patients would love 2 hours.
No, it's a very personal thing. Ultimately, that's my cop-out answer. It's there are options. I'll tell you what we do most of the time, but there are options. Clearly, the first question is the mastectomy question in the breast cancer. There are two reasons to do a mastectomy, right? It's if you have a breast cancer, or if you're doing for prophylaxis, if you have a gene, if you're a mutation carrier of a gene like BRCA1 or 2, right? So and it varies a little bit. The approach is slightly different between the two. But in general, what we now do, I think the reconstruction business has improved quite a bit in the last 10 years. We do most of our reconstructions at the same time as the removal of the breast surgery. So it's a one shot, one surgery usually, and we spare the nipple and we spare the skin, which is something that's relatively new. Most of the reconstruction is done with implants, usually saline implants, which are coated with silicone, not the texture kinds where there have been potential issues. And they're usually installed at the same time. There are different ways of putting the implants above or below the muscle. Most of ours are now placed in front of the muscle, or what's called pre-pectoral. That's what we are doing most of the time. But it very much depends on many factors. It depends on, again, why the mastectomy is being done. Depends on the woman's wishes. What exactly? What kind of reconstruction? Depends on the shape of the breast, the body habitus, other risk factors such as smoking, diabetes, and so on, which may make implant reconstruction a bit more complicated, or at least increase the risk of complications. Whether radiation is going to be given to the breast afterwards or not, that's a very big factor. We at our center, we are still implanting, we are doing implants even though radiation is envisaged after, although in those cases, implants perhaps in many centers is not the first choice. And the idea of what's called autologous, or taking a piece of tissue from somewhere else in the body, such as the stomach or the back, and placing it to reform the breast, is something that's more commonly performed when radiation may be envisaged. So I guess there are two kinds of reconstruction. One, in fact, is with the implants. One is without, is using the tissues, using your own body tissues. And there's two kinds there. One can either just swing over the tissue from either the stomach or the back, or do what's called a diet flap. In other words, cut the circulation with microsurgery, reconnect things. And so you have less of an issue of between the two sites, surgical problems and scarring. All of these options are possible often. And it again depends on the shape of the breast, why we're doing the reconstruction, and other medical factors that the patient may have. It ultimately depends very much on the conversation that you're going to have with a plastic surgeon. But I think that doing the reconstruction at the same time as the surgery is, I think, the standard right now in Canada. And I think the options of preserving the nipple and the skin, I think also is the standard therapy right now.
Yeah.
So I'm answering a very generic.
Yeah, that's a very comprehensive answer that addresses a lot of the question. Was a two-parter. I guess the other point I would say is age. Age has a big factor, right? Mm-hmm. And where the individual's at in their life, and how they want to move on. I've met women who that's their first set of thoughts. It's like, I need to have reconstruction ASAP. And I think there's a psychological component to that. They want to replace so that they don't want to look and see that they've had a traumatic, diagnosis and experience, and they want to move away from it. So you've covered it all. And I would understand that it's a very individual thing.
It really is. And it often surprises me. It surprises me how many women opt not to have reconstruction after a mastectomy. And, always saying, oh my goodness, no reconstruction. In fact, when you come to the operating room, the nurses are saying, why isn't this woman having reconstruction? Well, because she didn't want to. You have to want to. And but I must say, there are women of all ages are opting not to have reconstruction. And those women who opt not to have reconstruction are happy with their choice. Usually they're often the women who are very much happy in their skin, shall we say, for the pun, not to have the reconstruction, and they're satisfied with that decision. Of course, one can always go back later and have the reconstruction if one is not satisfied, and And that's that's doable, precisely because we can use the tissue from one stomach or from one back to recreate the breast. So reconstruction is not a final, you don't have to answer the question a final way at the time of the mastectomy. But certainly if you can, then you can avoid future surgeries potentially.
Yeah.
And
I think we will address this as we go along with the questions. There are a lot of women that opt not to. And I think those are some of the questions that will come up. And I think that'll get more of a topic of conversation as we lead on. Jen, I apologize for interfering. Go ahead.
No, I just wanted to actually interject in terms of, and perhaps Dr. Basik, you could speak more to the Quebec landscape. Do you see women who are in the more rural, remote areas, in smaller hospitals, like at the Jewish General Hospital, obviously having immediate reconstruction is well coordinated, that's an option. Are there challenges in some of the smaller hospitals? And do you see some of those women who are looking for immediate reconstruction coming into a city center like Montreal, or are they still able to accommodate that coordination at some of the smaller, more rural, remote centers?
That's an excellent question, Jen. And the truth is, I don't really know the answer to that question because I don't go to the rural centers that much, and I don't see that many patients from the rural centers. But I can tell you that 10 years ago, the idea of immediate reconstruction was limited to a handful of hospitals in Quebec. Now I suspect I know Center Stash comes to mind right away, and there are other places where there are plastic surgeons that offer that now as well. So it is spreading, but yeah, that's an excellent point. It may simply not be available in many places.
But to your knowledge, that's good to hear, though, that it is sort of a standard of care across the board and something that women across Canada could also ask and inquire about, regardless of where they're receiving their care.
Yeah,
I think,
yeah.
Sorry,
I'm going to go to question number 2. Yeah, I have question number 2, and it's ABC part. So it's 3-part question. A, how does the surgeon decide if they have adequate information about the size and location of the cancer in order to remove it all with a breast conserving approach? B, how common is it to require a revision for positive margins? And C, how common is it for the revision to also be unsuccessful? So we're getting more into the medical part of this now.
Or the surgical.
Yeah.
It's again an individualized question. It depends on the size of the tumor, the location of the tumor, and the size of the breast, and the age of the patient, and other complicating factors. Some large-breasted women, we can remove a tumor the size of an apple. Otherwise, that would, in other cases, in breasts that are smaller, that wouldn't be possible without a mastectomy. So it very much depends on the size of the ratio between the size of the tumor and the breast. We're actually more. I think there's also been developments in the lumpectomy world, what's called oncoplastic surgeries. Where we're actually getting much better at reshaping the breast after removing a good chunk of it with the tumor, and moving breast tissue to the side to replace the hole, shall we say, and reshape it with different incisions so that it looks much better. So I think that has also been an advance that we've seen in the last 5 to 10 years that is actually making us do much nicer, I think, lumpectomies and perhaps more lumpectomies. So that's especially those tumors that are in the middle of the breast, where often you'd have to, in the past, remove the nipple. Now we don't have to do that often. We can sort of go underneath and then fill in that space or do different incisions. So I think that's so it's very much it very much depends on the size of the breast, the location of the tumor, and it's something you examine the patient and you look at the possibilities and discuss with the patient, with the woman. This is going to look this way. There will be an indentation perhaps in this way, and the breast will change. Obviously, they will always be a bit smaller because you're removing something. And then to what extent it's smaller is something that's very variable, and the appearance of it. Tumors that are up in what we call in the upper inner quadrant, close to the sternum, close to the breastplate there, will have a larger cosmetic defect. There's also less breast tissue here up here, whereas most tumors are closer to the armpit, and there's a lot more breast tissue, and so the visual effects of a lumpectomy are much less. in that sense. And also below the nipple in the lower part of the breast, also in general, the cosmetic defects could be less visible, because that's not the part of the breast that's usually that's visible. And so it's easier to do the lumpectomies there and to have perhaps better results. But it's very much it's an individualized kind of basis. It's hard to answer that question. I've removed large tumors from large breasts and not done the same with smaller breasts, and vice versa. So it's very much individualized. That's the first part of the question.
I have a quick question around that answer, if you don't mind.
Yeah.
Your answer sounds like that's the dialogue, the conversation you will have with a patient sitting in your office.
Yeah.
Where you're saying, this is the option, this is how we're going to do this. Is that standard practice? Are all patients benefiting from a discussion such as the one that you just gave to us when they're seeing their surgical oncologist, or perhaps surgical oncologist, or perhaps a general surgeon, correct?
That's a very thorny question. My answer will be, I should hope so.
Okay.
But it's breast cancer is a very complicated, it's a very complex thing. It sounds simple, it's not. Most of the time when a woman comes to see me, the first question is, how soon can you get this out? But that's not the way it works. We often give therapy, sometimes even chemotherapy, before surgery to shrink the tumor, and for other reasons as well. And so the final result after the chemotherapy might be quite different than the result than when the woman comes in on day one. In fact, that's one of the ideas of giving therapy before surgery, is to shrink the tumor so you can do a lumpectomy, but otherwise you couldn't. So it's rarely a simple, direct answer. Sometimes it is. If it's a small tumor in a part of the breast where there's a lot of tissue, well, then it's sort of obvious lumpectomy. But the choice of a mastectomy is also a very personal thing, and there are many reasons where I would tell the patient, listen, from a cancer point of view, there's no reason to take your breast off. Yes, but I'd like to forget about this. I want you to remove my breast, and that's something that's a very individualized, very very personal decision.
Okay, so can we go to the B question, the B of the question, which is, I'll remind us, how common is it to require revision for positive margins? I guess your question is, how often do you have to go back because of positive margins?
Yeah, that's interesting, because there's what's quoted in the literature is very different from the experience that I have and several of my colleagues have had. There was a rate of a positive margin, going back to positive margin, about 20%, that has been quoted around a lot, and studies have been actually showed that that's what they had in the States. And I've never had anything nowhere near that high. And I polled some of my fellow colleagues at academic centers, I must say, and it's nowhere near 20%, it's closer to 5%. So it's not something that happens often, honestly. And now it also depends, there's another advance that I think has helped us a lot. And what we're doing now, the Jewish, and I think this is being done in other places too, we used to put wires into the tumor when we couldn't feel it, so that we could find it. These wires are placed in radiology, go through the skin, and they're left there with a little hook, and the hook is at the end of in the tumor. Then the surgeon has got to have a really good 3D brain to go to sort of follow that wire and then imagine where that tumor is and take out that little area around. Whereas now what we're doing is we're using radioactive seeds. So the radiologist is actually putting a seed right into the tumor, right next to where the clip is. We usually put a clip to where at the time of the biopsy. So we know really with much greater precision where that tumor is. So the advantage of that is we can remove less also of the breast, because we know exactly where to go. And so I actually was a bit afraid that would lead us with greater positive margins, because then we're moving less. And the breast tumor is not just like a little marble, it has these tentacles reaching out, and you don't see those tentacles. But so far, the experience that we've had has not been the case. We're actually moving, I think, less breast tissue, and we're not getting more positive margins. So these kinds of little things, little technical advances actually are quite important, and they do help us do better breast cancer surgery. So yeah, so the rate we have is, I'd say it's around 5%, and I think that's where more of this should be. I'm afraid that if you go out in the community, perhaps for general surgeons, it might go up to 10 to 15%, and I think that's unfortunate.
Okay, so it's a relatively low margin, I guess. Yeah, it's a. Okay, so her part C would ask, how common is it for the revision to also be unsuccessful?
Well, that's doubly rare, I guess. But I have had a couple of patients. I've had a few patients I've had to go back a second time, and I think exactly 2, and I remember their names. I had to go back 3 times. And once you go back a second, you have to start thinking about why. Is it because there's spread disease that you can't see throughout the breast? And the option of doing a mastectomy then must be considered. And again, the patient, which I went back for the 3rd time, she was absolutely against doing a mastectomy. I said, I don't care, you're not going to do a mastectomy, just keep on until you take out everything. And we did, but it's quite rare. It's very rare.
Okay.
The second time around, you're okay. I mean, the first time around, you're okay.
Thank you. Jen, I'm going to ask you to ask some live questions now.
Yeah, so one of the live questions came in from Jackie. Her question, 2-part, what are the dangers of implants, and is one type better than another?
Yeah, that's an excellent question. That's something that's changing a lot as well. I think most women have heard about these kinds of cancers, these very, very rare kinds of anaplastic lymphomas that have been discovered in some women with special kinds of textured implants. They're extremely rare, and they mostly seem to happen with this textured implant that Allergan was producing years ago. And that's something that is very, very unusual. Otherwise, implants could rupture. First of all, let me take a step back. The surgery of putting implants actually has more complications. Implants in the first month or so after they're put in, they could lead to infections. They could lead to what's fluid buildup around them as the body is sort of reacting to them or bleeding. So it's not unheard of that sometimes you have to remove the implant a week, 2 or 3, 4 weeks after the surgery because of these complications. There's no doubt that is something that happens much more when you have an implant than if you don't have an implant. Then you have more of the long-term kinds of complications. It can rupture, usually after many, many years. There's this thing called breast implant illness, which is also being now looked at more seriously. And that is, it's not well explained, not well known, but certain more sort of what we call systemic, more vague kind of issues that seem to be related to when the implant was placed in, such as fatigue of the woman and pains. So that's possible as well. I don't see that often, and I think that's something new that we're beginning to document and pay a bit more attention right now than we had before. So that's also something that's on the horizon. Is one type better than another? I don't know. We're using now the saline implants. Of course, they're coated with silicone as well, and more than the silicone implants. I think that's something that you should discuss with your plastic surgeon, really.
And actually, maybe while we're on that topic, just sort of, maybe we should have level set at the beginning, but you're here as a surgical oncologist, but you work obviously closely with plastic surgeons, and maybe you could speak a little bit to sort of the 2 different roles, right? And how you work together and what you should be discussing with your surgical oncologist versus what would be a discussion with your plastic surgeon, just from a clarification standpoint.
Yeah, I mean, the cancer part, the treatment of the cancer is something that we take care of, and removing the cancer and all the treatment that's associated with it, coordinating the chemotherapy, the endocrine therapy, the radiation therapy, that's what we do. The plastic surgeon essentially is there to do the reconstruction. Clearly, there has to be a dialogue between the plastic surgeon and the breast surgeon or the surgical oncologist prior to the surgery to understand what are the best options. Sometimes that dialogue occurs a few days even before the surgery, but that's something that there has to be some time. Usually what I do is I like to send the woman to see the plastic surgeon several weeks in advance. I mean, usually I prepare them and start talking about them perhaps a month or 2 or a month before the surgery, depending how much time there is, and then see the plastic surgeon. Then we meet again, and we continue this discussion that, with the plastic surgeon's data that was provided, the risk, the complications, the different options, and so on. So it's very much a very personalized thing. It depends on the shape of the breast, the size of the breast, the size of the tumor, and all the other potential risk factors that the woman may have that may or may not lead to increased complications. So these should be discussed directly between the two surgeons and with the patient, sometimes more than once before the surgery.
Yeah, great. So Jen, I'm going to go on to our submitted questions now, if that's okay.
Sounds good.
Okay, so I have a question here that asks, can breast density increase the risk of developing contralateral breast cancer?
Yeah, so that's a great question, because breast density is also something that we've been paying more and more attention to in the last, let's say, decade or so. It's something we didn't really pay attention that much before. Because it's clear that women that have very dense breasts have a high risk of breast cancer, and that's independent of the fact that the mammography perhaps is not as efficient and so on. There's something about the density of the breast, the kind of tissue that is forming that density, that seems to lead to an increased risk of breast cancer. Now, it's not a very high increased risk of breast cancer. It's not like having a gene mutation where the risk is 30 times higher. It's barely 2 times higher, but which is, if you have, there are many other risk factors that are related to hormones, which are more important. If you had a previous biopsy of the breast, it's about this, it increases by about the same. If you have about 4 glasses of wine a day, it's somewhat similar. So it's not a huge risk, but it does increase the risk. The question though is about the other breasts. Indeed, yes, there's a study out of the MD Anderson that showed that in fact, women with increased density do have a higher risk of contralateral breast cancer, developing breast cancer in the other side. But again, it's not super high. So I'm not, I don't think that the risk is so high that I would recommend to have a double mastectomy because of it. But certainly the follow-up of these women that have dense breasts is a little bit trickier, in the sense that a mammogram often is not enough. And I usually add at least an ultrasound. Sometimes I go as far as adding an MRI every year to make sure we see well into those breasts. So that of course causes increased anxiety, because you're having more exams, more imaging, more X-rays, and so on. So that's something that should be that I'm learning now more and more to begin to discuss with women before the surgery. Yet again, the risk is slightly higher of getting contralateral, but it's not that much higher.
Yeah, and I think getting back to your point, I think the clarity is not good enough. I think it's almost always associated to my risk is much higher if I have dense breast, where I think what we understand is that you should be screened better if you have dense breasts to be proactive in making sure nothing is missed. But ultimately, the concern always goes up to, oh, I have dense breasts. That means my increase is much higher than any other person.
It's nowhere near like having a hereditary breast,
right,
like a gene mutation. That's way higher. This is much smaller risk. So
we need to control the way it's discussed and talked about, because there is a lot of alarm out there, and the alarm is not placed in the right reasoning, when you're taking care of somebody with dense breasts. No,
I agree with you. I have not yet done a mastectomy because of that reason, but I certainly do follow these women in a slightly different way, in a closer way.
Right. So I'm going to go on to the next question. What are the benefits of oncoplastic surgery? Okay. Are there any drawbacks to this type of surgery?
Yeah.
Women have become very bright. They give a 2-parters in one question.
Well, no, oncoplastic is what I've already referred to a little bit. There's different degrees of oncoplastic surgery, because oncoplastic surgery ultimately means doing a lumpectomy and having your breast look great after that, and as much as possible like the other breasts. That's important, because clearly I'm removing something from one breast, and so clearly this breast is going to be smaller. So part of oncoplastic surgery is also potentially making the other breast smaller as well, doing a reduction. that gets quite complicated, I find, and also increases the time of surgery. And you have a scar in the other breast, which you didn't need otherwise, just for that reason. So that's one part, but I'm going to more concentrate on the breast itself, how to remove a tumor in the breast with, of course, the surrounding normal tissue, and make it so that the breast doesn't look like somebody punched it in the face and you've got this big crater there. So the idea is that we first of all, the incisions, where we make our incisions, where we make our cuts, is important. We try not to make them in places that are very visible. We often try to make them around the nipple, so they're hidden by the areola, or we put them underneath so they're less visible, or on the outside of the breast, so they're not actually in the skin of the breast. That's the first part. The second part is, once you remove the tumor, then it's to fill in that space with some breast tissue that's inside and sort of move it around inside so it doesn't look like there's a hole there. And of course, that depends on the kind of breast tissue. If the breast tissue is very, very fatty, then it's not going to do all that much because the fat is going to sink into. But if the breast tissue is a bit more, shall we say, more glandular and more fibrous, then it's going to be able to give some sort of consistency there. So these are all many issues to consider. But yes, oncoplastic surgery, the advantages are that it often does result in much nicer breasts after the surgery, and I have pictures, but anyway. And when I started doing it, I was quite pleased with the results, very, very pleased. I would remove sometimes, almost a quarter of the breast, and it looked like I hadn't done much, and it was really, really nice. The disadvantages, well, the first thing is that you're moving breast around a lot, so you're creating a lot more scarring inside the breast. In fact, the first time when I saw it being done, I said, oh my God, it's as if you're almost operating in the entire breast and then moving things around. So there hasn't been that much data regarding mammograms and imaging afterwards, but I'll be curious to see, because there's no doubt that I think there'll be more scarring, but so far it doesn't seem to have affected our ability to detect anything. The second part is a bit more tricky, and is the margin, coming back to the margin question we had before. Because when you remove, if you remove, let's say, a little plum out of the breast, then you check the margins around and make sure everything's okay. And then if you have a positive margin, you sort of know where to go because you've marked it, you know where to go. Oh, it's on this side, I've got to go and remove a bit more tissue. But if you remove the plum and then you've taken a piece of breast here, put it there, piece there, and piece up, then it's not so clear where you can go to get that extra piece of tissue. So that's been a problem. That's been an issue in terms of making sure that your margins are okay. To go back for positive margins can become a bit more complicated. So you have to have a really good idea, the surgeon does, when he or she is moving these pieces of breast inside, what they've actually done, so that if you have to go back, you know what to do. So it complicates things. So often what happens is that I find with the oncoplastic, you might tend to remove a little bit more just to make sure that you don't have a negative margin. And at the same time, you're moving things around anyway. So you can allow yourself to perhaps move a little bit more. I don't know if I'm clear, but
yeah.
So yeah, that's I guess that's one of the drawbacks.
The thing that I would highlight in what you just discussed is the aftermath. After you've done that, and if there is too much scarring, would that be of concern for an accurate reading of a mammogram?
Yeah,
because
yeah,
that would I would suspect that that's being discussed with the individual who's going through this, and that it is presented to her that the scarring could diminish the viewing. Is that a concern? At what level is that concern?
Yeah, I don't think it's a big. I think it's more of a theoretical concern. But I don't think it's I really don't think so far. I don't think it's been a real concern, a real practical issue that has come up.
Okay,
a theoretical issue, but I don't think, honestly, my experience so far is that it hasn't been an issue.
Excellent. Jen, I'm going to ask you to give him some live questions.
Yeah, absolutely. So this one's from Greta, and actually it sort of ties into the oncoplastic surgery question a little bit. And her question is, are all tumors not visible during surgery? Which I guess if you're doing a full mastectomy, well, then you're removing the full breast. Whereas if you're doing the lumpectomy, how can you explain the actual logistics of that? What can you see? How do you know that you're getting all of it?
So visible means I guess palpable. What I do is when I remove the I guess I'll use the analogy of the plum again, the little plum, then I can feel inside the core of that plum. I could feel the tumor. The tumor feels harder usually than the rest of the breast tissue. Not always. There's some tumors that are not that hard, and then it becomes very tricky, very hard to feel them. And so some tumors are more visible, and that's on the x-rays. And of course, my hands don't have x-rays. So I have to often look at the mammograms I'm doing the surgery to decide, what I'm doing. But most of the time, the tumors are harder. You can actually feel that they're hard. And what you try to do, I tell the residents that are operating with me, is you feel the tumor, and then you go around another 2 centimeters around or so, and you take out the breast tissue normal around it. So you're taking out the palm of the core and a little bit where the tumor is now. So most tumors, if they're very, very small, however, if they're less than, let's say, 5 millimeters or less than a centimeter, often you can't feel them. And then you've got that seed or that clip that has been put in at the biopsy, and that's what guides you. So what we always do is whenever we take it out, if there's a clip, we take an x-ray before we close. And the x-ray is done while the patient's sleeping to make sure that I've got that clip. And then I could see on the x-ray the actual tumor. And sometimes I can tell that, well, I've gone a little bit too close to the tumor. I could sort of see it on the x-ray, and then I'll go in right away and take out a little bit more on that side where I think I was a little bit too close. So I don't know if that answers the question.
Yeah.
Whether it's to the fingers and it's to the x-rays.
I have a question, a little bit on the side here. When the doctor and the individual the patient decides to have a mastectomy, do you go in and do first the removal of the tumor, or you do the mastectomy and then review the tumor? And why do you do that? Because would there be an option that you would not do a mastectomy if you would remove the tumor and then decide?
No, I think that that's always a question I get. A question I get less now, but I used to always get that question. What if you decide to do the mastectomy while I'm sleeping? I said, no, I don't do that. I never do that. We make that decision before we go in doing a particular surgery. We never go in to do a lumpectomy and then change our minds and do a mastectomy, because the patient's got to become aware and it's got to consent to that. It's an ethical issue as well. But no, so I take out the breast and then I feel the tumor. And if I feel that for whatever reason, even taking out the breast has been very close to one of the margins, then I'll go back and take out a little bit more to be sure that I'm cool. So yeah, no, I don't want to disturb. I don't want to take out the tumor and then disturb it and potentially spread cancer cells around it. So I'd like to take it all out and then we check it. And if we're good, we're good.
Okay, great. So I'm going to go back to the submitted questions. How do oncologists determine the need for an axillary dissection versus a sentinel node biopsy? Would you be able to highlight any key differences between the two and what people about to undergo this surgery would expect?
Yeah, so when I was a resident, we only did axillary dissections. So the idea was to remove all the lymph nodes. Now, there's a common misconception thinking that we're actually removing all the lymph nodes. There were some studies that were done by pathologists in the 60s where they actually took that lump of stuff removed from the armpit where the lymph nodes are and actually went through it really, really, really carefully, all kinds of chemical processes, and counted all the lymph nodes in the armpit. And the numbers were usually around 30 to 40. Now, I know there's very few women that I know that have had 30 to 40 lymph nodes removed. Usually when we do an axillary dissection, we remove about a dozen or so. That's usually the number. It's about that. So an axillary dissection is removing, quote unquote, all the lymph nodes in the armpit, which is where the lymph nodes from the breast are located. Not all of them, but most of them. That's where the tumors will go first. They'll go there. And so that's what we used to do. Then, but at a certain point, we were sort of wondering why we were doing this, because in the end, it didn't make that much of a difference if we removed those lymph nodes or not, because the important thing is whether the tumor had spread elsewhere. And removing the lymph nodes told us about its capacity to what I call swimming. Once a tumor learns to swim to the lymph nodes, then you're worried it could swim elsewhere in the body. And so it told us something about the biology of the tumor. And if we knew that it had gone to the lymph nodes, well, then that meant we should probably give some sort of therapy for the rest of the body, whether it be chemotherapy or pills against the hormones to control, to try to kill what might have left gone to the rest of the body. So the lymph nodes surgery was more of an indicator. It was telling us that the tumor is learned to swim, therefore it could spread. And so therefore we should give further therapy. The idea was not that much to remove every last cancer cells, but to understand what to do, what tells something about the biology. Well, you know, so some people had the idea then, well, if you're doing that and you're moving usually about a dozen lymph nodes, usually about 1 or 2 are positive, 1 or 2 have the cancer cells, rarely all of them do, sometimes it does, but usually not. Then why are you removing all these other lymph nodes? Why can't you just remove, you know, just a few, the ones that are closest? Is it true that all the lymph nodes are the same? Maybe some lymph nodes are closer to the breast and they're the ones who capture the tumor cells first. And indeed, that happens to be the case. So trials were done showing that if you just remove what's called the sentinel being the guardian, lymph node closest to the breast, it will tell you with a great deal of accuracy, you know, even what's left in the other, what's the chance of there being something in the other lymph nodes. And again, the important thing was not to remove every last cancer cell, but to understand whether the cancer had learned to swim. So if it had gone to the sentinel lymph node, well, then right away you knew that, okay, this is a cancer that has potential to spread, therefore we should do further therapies, whether it be chemotherapy or endocrine therapy or more. So removing a few lymph nodes is clearly better than removing more lymph nodes. Why? Because these lymph nodes, not only do they drain the breast, they also drain the arm. It goes through the armpit. So if the more lymph nodes you remove, the more likelihood you have of this thing called lymphedema, which is a swelling of the arm. Why? Because the liquid, it's blocked by all the scarring that you've done removing those lymph nodes. It doesn't know where to go, and so it starts to back up. And lymphedema it could be a serious issue in a sense. It could be something that could handicap a woman for a lifetime. So the advantage of doing a sentinel lymph node, removing just a few lymph nodes that were close, was in fact to try to prevent lymphedema. The less nodes removed, the better, the less of a chance that you'd have lymphedema. So I don't know if I've answered the question.
Yeah, just two quick follow-ups on that. One would be detection of cancer cells in the lymph nodes. Is there a measurement there? Is there a high level, low level? Does the surgeon measure that? Is that measured?
No, the surgeon doesn't measure, the pathologist will though. So we often, every surgeon will tell you, every breast surgeon will tell you that you often can't tell whether the lymph node has got cancer cells or not. It's really hard to tell just by feeling it, looking at it, even when you're there. Sometimes it's obvious, but often it's not. So the pathologist has to go through every single lymph node, bisect them, look under the microscope, and then count to see how big if there's any cancer in there, how big the cancer is. So that's what the pathologist will tell you in a few weeks afterwards when they're analyzing the tissue.
Yeah, and my next question would be follow up to the lymphedema answer. Is there less lymphedema because of the sentinel node versus all the there is?
Yes. The incidence, you still can get lymphedema. It's more like 5% of the time only, whereas when you did remove all the lymph nodes, it'd be up to 25%. 1 in 4 women have lymphedema, which is quite a bit. And then if you do radiation to that area, to the armpit, that increases it even more. So yes, there's less lymphedema. That was the whole reason to do the sentinel lymph node, is to avoid that complication.
Excellent, thank you. Jen, we'll take some live questions.
Yeah, sounds good. So this one is regarding actually radiation, very topical. So the question is around what should some of the concerns that a patient maybe should be aware of with radiation. So this particular patient has a tram flap reconstruction on one side and an expander on the other side. And what are there concerns that she should be looking for, maybe considerations as she starts to receive radiation for both of those, given that she's got autologous reconstruction on one side and the expander on the other side?
So, okay, first I'm going to say I'm not a radiation oncologist. Second, yes, radiation causes short-term and more long-term side effects. Short-term, it will cause the burning of the skin, sometimes worse, sometimes less worse. More sort of middle term, it could cause the breast to shrink, to contract. And that's why we often put expanders. We want to put a permanent implant later. We first put expanders so we can actually have the skin a bit already stretched. Radiation will come and contract the skin, will make it sort of scrunch up until the expander prevents that to some extent. And then there's more long-term rare side effects of radiation. Well, it could also scratch the lung, which is underneath, rarely now scratch the heart. and really, really, really rarely give you very rare kinds of cancers in the area as well. And I've seen like two, three such cases my whole life. So it's extremely rare. So radiation, it makes you also a bit tired while you're doing it. It's usually, now there's new radiation protocols where radiation is given in much shorter time than it used to be. It used to be a month, every day for a month. Now it's given 5 days, 10 days. There's short protocols that have been shown to be just as good as the month-long ones. So we hope, although the dosages perhaps are stronger in those 5 days, but we hope that the ultimate side effects will be less. We'll see. So I don't know if I'm answering the question.
Yeah, I think that helps in terms of just understanding some of the, especially around the expanders and why the recommendations are what they are.
Yeah.
Kathy, back to you.
Sure. So the next question is living flat. I have decided to live flat, but I would like the scars from my surgeries fixed. How can I find a surgeon who would help with an aesthetic scar surgery, and what type of surgeon would perform the surgery? Also, is there specific wording that can be used to help have this covered through the public health system? So I guess aesthetically, the question is around, is this going to cost, or is it part of the surgery to begin with? And how can this be fixed? And I'm guessing this is a plastic surgeon question.
Yeah, but in general, I would say that any surgery that's done with a woman who has breast cancer is in general covered by the public health care system, right? So even if you had reconstruction or further reconstruction or further touch-ups, I think that is usually covered because you've had cancer. It's cancer surgery. That is a general blanket statement, which I believe is true. In terms of finding a surgeon, again, it depends who did the original surgery. You might want to go back to that surgeon if possible. Potentially plastic surgeons would be the people I'd go to they're experts in cosmetics, and they could make nice scars usually. Not always, but usually.
Is that, it's something that we hear quite a lot from patients who decide to live flat, is that sometimes, again, depending on the center, there's a plastic surgeon involved to help sort of really like give minimal scarring and sort of finish things off really nicely. Whereas not all patients have access to that. And we've heard some concerns from patients who said, I'm not happy. I decided to live flat, but I really wish that I had access to someone who could have maybe made the scarring a little bit more minimal, or whatnot. Is that standard of care that both the plastic and the surgical oncologist should be there, or no?
No, that's a good point, Jen. It's not standard of care. I'd say most of the time the plastic surgeon's only involved when there's a reconstruction, and they're not involved in these cases. The general surgeon, the breast surgeon, surgical oncologist deals with them. I guess the plastic surgeon is busy enough with the reconstruction that they don't come in for these kinds of cases. That's a good point. Yeah, I have sometimes gone back to do some touch-ups of some of the scars, most of the time not because of the scars, but because there's sometimes some fat tissue that's around the mastectomy. It's not really flat, it's bumpy. And then I've gone back to remove some of that fat tissue, and with good success afterwards. So that's not a routine. Because of how busy they are, I suspect that might not be something that will become routine anytime soon. But I think there's no doubt that that's something that you can be always referred to a plastic surgeon afterwards. But I don't know what more to say.
No, that's
a good point. That's something that's brought up perhaps more.
So quickly, if a woman in her youth, like a young woman, 35, 40, had 10 years ago or 15 years ago, because the surgeries have changed, went flat, and now decides to want to have, breast implants or correct whatever was done, is it harder for a surgeon to work on women that have already had this for X amount of time?
Yeah, it is. I mean, usually there's less skin to work with. The advantage, and this goes back to the very first question I didn't mention, is but the advantage of doing the immediate reconstructions, you have a lot of breast skin. And since we're now doing the skin sparing mastectomy, we're actually sparing a lot of the skin, then that, you don't have to stretch the skin to have this implant come in. It's actually there. It's like an envelope of the breast. You remove what's inside, you've got this envelope waiting for you. But if you do usually a mastectomy without an implant, well, you remove that skin, otherwise it would be all creased up there. So you've got much less skin to work with. So you've got to get that skin somewhere, and that's why you usually get it from another part of the body, and that's why you do the autologous reconstruction. You get, flaps from the belly or from the back, and they come with part of the skin, so that you can use that skin to cover the reconstruction. Yeah.
Well, what is the rate of somebody having a bad situation after removing their tapes, from having the mastectomy, and then something goes wrong or some surgical problem happens? Like, how often does that happen? Do you see that a lot? Or
like an infection of the wound or a hematoma?
Yeah.
No, it doesn't happen often. I mean, it does happen. Every single surgery has a risk of complications like that. Those are sort of the standard surgical. It probably happens less than 5% of the time, but it could happen. Yeah. I've had some women that with the mastectomy where the wound got infected, we had to open it up, and it was a very, very long procedure then for it to be healed. When the scar was not as nice, of course, in those situations.
Yeah. I guess everything is possible. Yeah. Okay, Jen, do you have any other questions coming up there? Sorry?
She's got a lot of questions. I'm seeing.
Yeah, she does.
So Jacqueline says, first of all, she loves the conversation. And her question is if you could speak to how the tissue expanders work, their failure rate, and what you can expect when getting expanders.
Again, a question for the plastic surgeon, perhaps. I'm punting.
Well, we have you today, so you get to wear many.
Yeah, they work. They work. There's a valve essentially. It's something that you can. It's like a pocket for a saline that you can sort of every so often you simply inject more. You open the valve through the skin, and with a syringe you inject more, and so you make it grow bigger over weeks usually. The idea is to slowly stretch the skin, so that then when the skin is stretched, you remove this and you put in the real implant. That's sort of that's the idea. What's another part of the question? The failure rate. The failure rate is usually less than with an implant because you're not dealing with a fully stretched skin. So you can start off with something much smaller. So they often don't fail. But as you start to expand them with the fluid, then you sort of reach a point where it starts getting really, really tight. And then you got to wait for the skin to sometimes stretch and sort of adapt to it, and sometimes it doesn't, or it takes longer. It takes longer for it to adapt, and so that's very much. It depends on every situation. So I wouldn't call that a failure rate. I would just say that it takes longer sometimes, and yeah, sometimes you don't expand as much as you'd like to. Depends on the stretchiness of the skin. Elderly women have much stretchier skin than younger women, for instance.
And do you end up with, so one of the other things that we've heard from patients is that sometimes you end up with these expanders in for longer than you wanted because you're sort of back on the waiting list for another surgery, right, to have the implant.
That's true. Unfortunately, yeah, that's thanks to our wonderful healthcare system. It is wonderful, but it has disadvantages in that you might have to wait. And then the women that have expanders are waiting for implants sometimes could wait a long time. And I've had some of my patients that have unfortunately been waiting a long time. And well, COVID then happened, of course, when COVID happened, and all this kind of surgery was put completely in the back burner. And so that added a year of waiting. And so sometimes you're not comfortable with that, that skin stretching. It sometimes feels like a rock. It's so tight, and that it can cause quite a bit of pain. And so I've had a few patients, unfortunately, because of the COVID times, that have had to wait. And but you shouldn't really have to wait. And again, you shouldn't have to wait more than a year, or hopefully much less than a year to get it replaced. What happens sometimes is you have the radiation, and then you have chemotherapy, or you have the chemotherapy and then the radiation, and you have to wait for that. And that usually takes about 6 to 7 months, and then you have your surgery. So it depends on every particular patient and what kind of treatment follows the surgery.
What happens with surgery, implants, radiation? Does that ever, what happens with radiation in your implants? How does that?
Again, that's controversial. If you read the literature, a lot of plastic surgeons will refuse to put in implant if radiation is considered. Yeah. We've been doing that. Sometimes you do get a contracture of the breast, but we've also done well with it, I think, in general. So I think it's doable. I think you can have radiation over an implant, but it is somewhat more risky. I think that has to be explained.
Right. Right. Jen, go ahead.
So a question actually around shoulder pain, and this is something we do hear from patients from time to time. So someone complaining that they get really bad shoulder pain since their surgery. Any insights into this? I know we've had patients complain about frozen shoulder. How do you mitigate this? Who could they see about this? Do you go back to your surgeon to discuss some of these complications?
Yeah, well, you have to figure out why you have the shoulder pain. And that's sometimes very complicated. If the shoulder pain is timed to the surgery, it may not necessarily be the surgery itself. It may have been just the fact of laying like this for an anesthesia for about 2-3 hours, and then stretching this. The pain might have been to mechanical reasons that have nothing to do with the actual implant or the surgery itself. And so you have to try to figure out, and sometimes it's not that obvious. I mean, physiotherapy is key. Perhaps doing x-rays, ultimately maybe even doing MRIs. I've had several patients that have had the shoulder pain and turned out to be that they had tendonitis in the shoulder, and a nice injection of cortisone in the shoulder relieved their pain. So it depends, but it's true that sometimes the implants, and there are some women that have had pain after implants or pain after surgery that has gone to the shoulder, sort of around up. Yeah, it's there's no one size fits all answer. You really have to try to investigate and find out why that pain is there. And sometimes I've sent women to the rheumatologist for injections or to understand better whether it's. I sometimes have done bone scans, worried that there could be a metastasis spread to the shoulder, and more often I've almost never seen one that way. But what I've sometimes seen, the bone scan will tell me there's inflammation there. And so those kinds of things then require a bit of arthritis is beginning perhaps, and require an injection or some anti-inflammatory. So you really have to individualize. You have to figure out why that is happening. But I've seen that. Yeah, it's a real concern.
Okay, thanks.
Good. You can ask another question. Do you have any more live ones?
We do. Several live ones still. So in terms of and this is a little bit more for a medical oncologist, but again, Dr. Basik, we have you today, and I've heard you speak about Oncotype DX, so I know you can speak to this. Someone asking, so she has 2B estrogen positive, HER2 negative breast cancer, but asking about the Oncotype DX test, and maybe if you could speak a little bit to what that test is and how that helps patients and physicians make informed decisions.
So the Oncotype test is a test that is a molecular test that's done on the tumor. So when I tell the woman, we're going to do this test on your tumor, oh my God, you have to operate me again? No. The tumor is out, and in pathology, and we take a slice of that tumor that's already out in pathology, and we send it to a laboratory that's in the States, and your government, my taxpayers' money, your taxpayers will pay about $4,000 for it, more or less. And that comes out with, it uses the change in certain molecules inside your tumor. And it comes out with a score, which is called the Recurrence Score. That Recurrence Score tells you what is the risk of your cancer coming back in the next 10 years. Now, that test was developed for a particular subtype of breast cancer, those that are hormone receptor positive. Those are dependent on hormones. It only works for that. For that kind of, so that's still the majority. It's about 70-75% of breast cancers, but it works for that particular type of breast cancer. So, and it was originally developed for a woman that didn't have anything in her nodes, because the idea was if once the tumor got into your nodes, then you needed chemotherapy. Whereas if it didn't get into your nodes, well, then it wasn't quite clear who should get chemotherapy, who shouldn't. And using this test was really helpful, because if your prognosis, if a chance of your tumor coming back was higher, then we'd give you chemotherapy. If it was low, we wouldn't give you chemotherapy. So it really is a really great test for that. It really helps women avoid chemotherapy that in the past would have had chemotherapy. And vice versa. Maybe some women with very small tumors that wouldn't need chemotherapy, all of a sudden you saw these changes, this recurrence score which is coming high, and we'd give them chemotherapy and do them good. Recently, in the last year, there's been results coming out of a big trial in which it was tested also in women with positive nodes, only 1 to 3 positive nodes. So relatively limited nodal disease. And in those women, especially those postmenopausal women after menopause, it was shown that if your recurrence score is low, even if you have positive nodes, you don't benefit from chemotherapy. So that's really a big change. It's going to make us give a lot less chemotherapy, and it's going to change how we do things, because often what we do, if a woman came in with nodes that were positive, we knew we could feel them, then we'd go right away, it's the chemotherapy, and then we'll do the surgery. But now we're not sure anymore, because these women might not need chemotherapy at all. I have, in fact, a patient right now in that, that very exact quandary, trying to figure out whether she needs chemotherapy before I'm operating her. And I might do the surgery just to find out how many nodes are there. But so things are changing, things are fluid. So I think the governments now have to look at providing Oncotype DX in stage 2B patients, in patients like this woman who have positive nodal disease, because a lot of these women now will be spared chemotherapy. This is postmenopausal. If you're premenopausal, no. In those situations, the Oncotype did not help, and you still need the chemotherapy if your nodes are involved.
Yeah, and if you can do without chemo,
Yeah.
that's a great option.
Obviously.
Go that.
Yeah.
So another live question. Paula says that her DCIS cancer was removed with clear unresolved edges, but the margin was greater than 1 millimeter. Is there benefits to going for a second surgery to remove that margin?
That's a good question. That's a bit controversial, because guidelines came out in the States, our happy neighbor to the south, suggesting that you need a 2 millimeter margin for DCIS, but not for a regular cancer, which I thought was a bit weird. In fact, those guidelines are not very well supported, in my opinion. What we've been doing for the last 30 years is we and most other academic centers, many other academic centers, is we just to be sure that we've caught the tumor, and that there's a bit of margin between the edge of the tumor and where my knife has gone to resect. There's a bit of space. Even if the space is tiny, that has been shown to be good enough in terms of what we do. Why? Because often in these cases we give radiation, and we sort of sterilize, shall we say, the rest of the breast. And so we don't usually go back when even if the margin's really close. It has to be that the tumor cells are actually touching where my knife went. So then I really don't know there's something on the other side of my knife that I'd left behind. Then I have to go back. But if I got it so that even if I'm close, I don't go back. Again, this is controversial. In the States, there's some centers, Memorial Sloan Kettering, one of them, where they want a 2 millimeter margin. I think the data is not very, very strong that it actually makes a difference by doing that. So that, I guess, so to answer the question, I would not go back, but I'd make sure there'd be radiation therapy.
Helpful.
Okay. Wow. I think I'll ask my next submitted question, Jen.
Okay.
I have had five bouts of breast cancer, all small tumors. A few months ago, an ultrasound showed a suspicious lymph node, which is to be followed up with another ultrasound. I have already had a mastectomy on that side. Would a surgeon go in to take out the suspicious lymph node? If not, what is the likely treatment?
Yeah, it's a complicated situation, and I won't be able to answer it without all the data. It depends on what kind of cancer it was, the hormone receptors, what kind of therapy she's had, and probably at this point, also whether there's any spread anywhere else in the body, like the patient would need a PET scan to make sure there's nothing else happening. The fact that it's come back like that, I think such a lymph node has to be biopsied at some point if they're worried about it. Suspicious, and there's suspicious and there's suspicious. If the radiologist is worried, then they should biopsy it. And then it depends what the biopsy shows. If the biopsy shows cancer, and it's a kind of cancer that, again, it's very individualized, but in general, yes, we would remove it if there's nothing else anywhere else happening in the body. Although sometimes if it's a kind of cancer that responds well to chemotherapy, such as triple negative breast cancer, or HER2 positive breast cancer, we might give some therapy before the surgery to shrink it and then go and take it out. If that's the case, and what we do, we would probably put a clip inside the lymph node, because if we give therapy, it might shrink so much that we won't be able to find it anymore. We won't know which one it was. So it's a complicated answer I'm giving, but it really depends on the situation. And the answer is simply yes, that a lymph node can be removed again. but you have to be biopsied and put in the context. The other option is to do radiation therapy. I've had also that as an option when the lymph node, it comes back in the lymph node. And if for whatever reason, perhaps a surgeon has already been there 2 or 3 times and it's very, very scarred down, you can do radiation and deal with it as well.
I guess there would be a consultation amongst the
sure.
physicians, right? Like the medical oncologist, the surgeon, and the radio oncologist, correct?
Yeah, clearly, this woman has been through a lot, and I'm sure has, has specialists that are looking at these things, and there has to be a two-board or consultation to decide what to do next. In fact, we had one at our tumor board this morning. It was very similar to that.
Right. It's not straightforward.
No.
Yeah. Jen.
So we have a question from Jacqueline. So you mentioned more scarring with oncoplastic surgery, and we discussed lymphedema with some of the lymph node removals. But if you've had oncoplastic surgery, does this mean a higher risk of lymphedema, or is there really no risk or impact if you just had the oncoplastic surgery? Okay, so when I say lymphedema, I mean lymphedema of the arm, right? So as long as you're not doing anything different in the lymph nodes, you're doing a sentinel lymph node, nothing's going to change with what you're doing in the breast for the arm. However, there is such a thing as lymphedema of the breast as well, although that usually happens because of radiation therapy. Radiation therapy can affect the lymphatics, the drainage of the breast, and so the breast often turns into this. The skin gets thicker, and it's thicker and it's more rigid. And that's a form of lymphedema of the breast, if you will. But in either case, I don't think the oncoplastic surgery is going to change anything as far as lymphedema is concerned, whether it be of the breast or the arm. Certainly not of the arm. Okay, that's helpful for clarifying. Francine's asking a question around having had surgery done by a general surgeon last year and the difference between sort of a surgical oncologist and a general surgeon, and whether she can be confident in the surgery that she received. Maybe you can speak a little bit to that in terms of what patients might be receiving in some of the smaller centers and who might be performing those surgeries. Yeah, I mean, amongst surgeons, it's considered that breast surgery is not very complicated. But now with oncoplastics coming in, I actually went to take a course in oncoplastic surgery. It was not obvious, and you want to learn from other surgeons. So any surgeon that's doing breast surgery, whether it be in a small or large, and it can take such a course, and many do, to improve their skills at doing breast surgery. So it's something that's available, and it's given relatively frequently to general surgeons as well. So I don't know. Again. I don't think so. Is my answer. I hope not. I don't think so, because it's not usually very complicated surgery. However, it's true that breast surgery has become more refined, shall we say, in the last few years. And those are questions that one should be asking, perhaps, of one surgeon, whether it be a general surgeon or surgical oncologist in a large city.
My question would be the same around that, is that in a big center, in a cancer center, I would imagine that there's a pool of surgeons that are used for breast cancer specifically. Yeah. And somebody that is a general surgeon would be also part of a team, if he or she has specialized in doing breast cancer surgery as well. Correct?
Yeah, absolutely, totally right, Kathy. And it's more than that, because the care of breast cancers is multidisciplinary. As I've already said a few times, sometimes we give chemotherapy before we do the surgery. And that's a decision, that's something as a surgeon I've got to be aware of, because otherwise I'll just go and operate, right? So I have to be aware of all these options, these alternatives, and I have to discuss it with the medical oncologist, sometimes with the radiation oncologist. It's not infrequent that I call the radiation oncologist, call the medical oncologist, and discuss with them before surgery to figure out what are the actual alternatives. And sometimes I have the patient meet them before surgery, before we decide on surgery or the type of surgery, to figure out what is the best way to go forward. So breast surgery is, as I said, surgically speaking, it's not very difficult, although, as I said, it's more refined now. Mm-hmm. But in terms of the management of cancer, it is not simple, I think. And so I would hope that the woman in Rouyn-Noranda is getting similar kind of care that she's getting in Montreal, but I sort of am not so sure about that.
Yeah, but one gets what they get depending on where you live, right? in this country?
I guess so. So
Yeah.
it's the way I think when a woman comes with a breast cancer, my thinking process takes into account a lot of different alternatives that may not be available or obvious to the surgeon in a small community.
Well, and that's some of the questions we get as well, right? In terms of women accessing different, like even some of the immediate reconstruction, that can oftentimes be a little bit more challenging to access in a more rural, smaller community setting than, for example, where it's just standard of care at, at a center like the Jewish General Hospital. So so there's a really interesting question here that's sort of great for a little towards the end of our session. And I know, Dr. Basik, you do a ton of research and you have a lot of insights into sort of what's coming down the road. And you've mentioned that we've refined surgery over the, breast surgery over the past few years and decade. And so this person's asking, what direction do you hope to see surgical oncology go in the next 20 years? And what changes would you love to see? So I think it's an interesting open-ended question. And I know some of the research that you're involved in is very forward thinking. So maybe you can share some of those insights with us and everyone on the call.
It's interesting because that's moving target. I think that we're going to be operating. You see, it's
a trick question.
A trick question because it doesn't take into account the changes in society. I would never have predicted that we'd be doing a lot of mastectomies that we're still doing now.
Mm-hmm.
And that's not a cancer reason, right? It's more of a personal, societal, or anxiety reason often, right? And that's not something I would have predicted. I would have predicted that we're going to be doing less and less surgery. I think I've been involved in a study, leading a study, in fact, in which we might stop doing surgery altogether for breast cancer as our medications that are targeting the breast cancer get better. What we're seeing with, for instance, women getting chemotherapy or HER2-directed therapy, we're coming often to the surgery where there's nothing left of the tumor after therapy. And so the question the women were asking, why do I need surgery? And that's an excellent question. So I've been trying to lead the effort to avoid surgery in such women that have very good response. And I think that's where we're going to end up. We're going to do less and less surgery eventually as we get better and better to directly attack the cancer cells. And so we're going to eliminate them before surgery. We don't even need to do surgery anymore. I think that's the future. On the other hand, I think we might end up doing maybe a bit more surgery or certainly more radiation therapy in women have spreading of metastatic breast cancer. As we get also better with our medications, we might then go back and remove what's left or remove, different parts of the organ, for instance, parts of the liver or somewhere else, with the hope then that we can actually cure these cancers. So I think we might see more of that in the future, although I think I'm getting a bit less optimistic on that second front than I was maybe 5 to 10 years ago. But certainly I see less aggressive surgery, less surgery. But then again, we're doing more mastectomies than I thought we would be doing. Why? Not because of the cancer, but because women are asking for it. And then you've got the MRIs. As we do more MRIs, we're finding these little things which are pushing us to do more mastectomies, right? Because we find these little things, we're not quite sure what they are, tiny little early cancers that may not have been killed by the radiation that they would get. And we end up doing mastectomies because we're finding. So I don't like MRIs, but unfortunately, they're pushing us to doing more surgery, which I'm not sure is really necessary.
So would you say, I guess, to sum it up, that lobular cancer and removal of BRCA reason, those are the main ones that you would continue to do surgery? Because with lobular cancer, I think there is no other choice, correct?
No, definitely there is choice. Oh, no. Most of my lobular cancers do not get a mastectomy, but most, if not all of my lobular cancers get an MRI, or often get an MRI to make sure there's nothing else. And if we're clear, then no, they don't need a mastectomy.
Okay.
But yeah, you definitely have to check. No, the indication for mastectomy essentially are the genetic ones, as you said, or again, if the tumor is located in such a place that removing it would create such a big deformity in a relatively small breast that it would look terrible. So
how are we going to change the mindset?
Well, as I said, I'm working to make it so that we can do less breast cancer surgery as we get better at therapy, but I can't change society.
Well, in the system as well, we hear from a lot of our northern patients, right, who have to fly in for their surgery. And then if they decide to have a lumpectomy, then they have to do radiation and they have to stay away from home, away from their families and whatever else for however long. So sometimes it feels like the only option or the option that makes the most sense to get them back home where they could get chemo is to have a double mastectomy, and then they're not living for however many weeks away from home, which is really challenging given that we have so many women in this country living in remote, very, very remote communities, right? So it definitely speaks to our earlier point around the health system as a whole and the access that you have and the equity or inequity across the country.
Yeah, and I'm sort of tiptoeing around that, obviously, but yeah, you're totally right.
We'll say it. The inequities.
Well, yeah. But
we
we don't even have to go as far as north. You're touching like Labrador, Newfoundland. I mean, a lot of the women say just do the mastectomy, and I don't want to fly back and forth from Labrador to Newfoundland. And in those smaller provinces, in the maritime provinces, it's a different. I think because the system is not the same as a larger city like Montreal, Vancouver, Toronto. You're meeting up with different scenarios.
At least it's not going to be like when I was a resident, I was a fellow in the States at a big cancer institute, and we had a patient come in from a rural area without insurance, and we had to do a mastectomy because she couldn't afford the radiation. At least we're not doing that.
Right. Yeah.
There's room for improvement, but to your point, Dr. Basik, we don't have the insurance issue that's prohibiting that access, at least. So there's a couple sort of not necessarily, and we have a few minutes left, but they're a little bit more back into the radiation or endocrine therapy piece. But in terms of, and I know, again, knowing that you're not a radiation oncologist or a medical oncologist, but maybe looking at if you can comment on the risk when the whole breast is involved in radiation versus sort of not the whole breast radiation therapy. Like, is there a benefit to that? Is there a greater risk?
I'm looking at the people who are writing, and I recognize some of them. First of all, hello. I'm going to write an email to perhaps answer that question in greater detail because I have an email pending. But to answer here, there's two kinds of radiation therapy. You can give radiation to the whole breast, which is the traditional one. But for many, many, many years, radiation oncologists have been also trying to give radiation directly to the tumor bed where the tumor was, to try to spare the rest of the breast. And that we have radiotherapists that do that at our center and others as well. There's different ways of doing that. But there's an advantage that it spares the rest of the breast, but there are also disadvantages, I find. First of all, there's could be quite a bit of scarring in that area where that focused radiation is given. And and so I've seen some cosmetic results that I haven't been very happy with in the long term for these kinds of very focused kind of radiation. Secondly, the long-term results do show that cancers could still occur a bit more often in the other parts of the breast that have been irradiated. The risk of getting breast cancer recurrence in general after lumpectomy, if you don't do radiation, is close to about 40%. It's very high. And radiation really brings it down to about 10 to 15%. So radiation is something that's given locally. It does sometimes scratch the lungs underneath, but in general, it generally is quite well tolerated. Now with the new protocols that are giving it much shorter, it's easier to take, I think. But it definitely has an advantage to decreasing the chance of a recurrence in the breast. It's very, very clear. It may not add a day to your life, but it certainly, if you don't do it, it adds the probability of you having a cancer come back in that breast in the next 5 to 10 years is significantly higher. I mean, from 15 to 40 is at least about twice as high. Yeah,
that's quite a large gap. Like that's That would make it,
That depends on every cancer. I'm sort of generalizing here. But anyway.
yeah. I guess it depends on the tumor, right? The biology, the grade, etc. Jen.
So I think, well, we're sort of getting to the end of our session. So I really just wanted to thank Kathy and Dr. Basik for being here. It's always, I always learn a tremendous amount. Kathy, listening to you ask all the questions, and then Dr. Basik, it's a pleasure to see you at least via Zoom. I know one of the patients on the call mentioned that it was nice to see your full face and not just you in a mask, is how everyone's used to seeing you. So thank you for joining us. Great to see your full face. Thank you for sharing your knowledge with us. And then again, thank you for the sponsors for today who were supporting this session. So Viatris is our gold level sponsor. Our silver level sponsors, Novartis Oncology and Roche, and our bronze level sponsors, AstraZeneca, Knight, and Ontario Trillium Foundation, and Pfizer as well. So thank you again, Kathy and Dr. Basik, for joining us, and everyone for your great questions and participating in this session. Have a great afternoon.